Morning, Mr. Dunlop.
Morning, my lord. The first witness this morning, there's a restriction order in place, so we won't be using the witness's name. For your benefit, the witness number is SCI WT 0647, the usual 5 zeros and a 1.
Good. Thank you.
Thank you. Good morning, ma'am.
Good morning.
As you just have heard, as I was explaining to his lordship, there's a restriction order in place, so we won't be using your name. But if I could also remind you not to use anybody else's names, because I appreciate you're going to be talking about your youngest son quite a lot in evidence this morning. A great deal of your evidence concerns him, so I'll try and use youngest son just to kind of prompt you so that you don't say his name. Now, you've provided us with a statement, and we see in paragraph 3 of your statement that, and do you have a copy of that statement in front of you?
I've got it on a laptop. So
perfect.
Yeah.
And we see in paragraph 3 of that statement that you're an unpaid carer for your son, who you've raised since he was 15 months old. What age is your youngest son now?
29.
And are you a full-time unpaid carer for your youngest son?
Yes.
And how long have you been doing that for, the unpaid carer role? Since he was born, or in a full-time basis, I meant, sorry.
Probably since he was, probably officially an unpaid carer from 15 months. Up till then I was part-time work because of marital considerations at the time.
And during the pandemic, which is the period we're interested in, were you a full-time carer for your youngest son during that period?
Right, I think that's us ready again, Mr. Dunlop.
Yes, I think we are.
Can I just say to the witness, don't worry about that. It's the most natural thing to use your son's name. Try not to do it again, but you're not to worry about it.
Sorry.
Not at all. On you go, Mr. Dunlop.
And I think I've recommended if you write down youngest son on a bit of paper, I have to do that with people's names as well, so that may help.
Block capitals now.
Thank you. I think you were, before we had that short break, I think you were explaining what conditions your youngest son had, and I think I'd asked, did it affect him in the kind of aspects of his daily life? So in terms of your youngest son, does your youngest son, is he able to look after himself?
No, my youngest son isn't able to look after himself. There's no concept of money, no concept of how to get places. He could probably cross a road, but he wouldn't know any of the safety issues around it. He needs help with making choices about food. He needs help with getting to all his places where he enjoys his clubs and different things. So he really, I've got welfare guardianship for him. He really requires quite a lot of support to do activities.
Thank you. And you tell us at paragraph 10 of your statement that since the pandemic, your youngest son also now suffers from celiac disease, which is a chronic immune disorder. Did the pandemic play any role in contracting that condition?
No.
No. And as you just indicated in your evidence, in paragraph 12, you tell us that your son has required care all of his life, and at paragraph 14, you say that he receives little support from social work. When you say little support from social work, is that something that's been a feature of the care package throughout, or is that something that's related to the pandemic?
That is a feature throughout, right. But I think it became much more obvious during the pandemic that there was nowhere to go, nowhere.
Well, I'll talk about where he could go, but in terms of, I suppose, in the domestic home, the care, does your youngest son receive any care packages from social work? Do social workers come in during the week to your house and assist your youngest son with anything?
Social workers will come, do the minimum, which is I think they have to see you every 3 years to check your package of care is all right. Apart from that, you have to go through the normal inquiry routes to social work departments. So you start you don't have a named person or anything like that.
I won't dwell on this. If I'm understanding correctly, what you're saying is that there wasn't a great deal of social work involvement before the pandemic, and that remained largely constant throughout the pandemic. Is that correct? Well, let's not dwell on that then. At paragraph 16 of your statement, you discuss your son's social life prior to the pandemic, and you tell us that he attended a club 4 mornings a week. How many hours was that for in each morning, roughly?
He would go in about, well, it depended each day. It's probably about 5 hours. It wasn't just a morning. It's kind of went morning to afternoon. So one day he goes in later in the day, but I would think 4 to 5 hours a day. Okay.
And in terms of, you identify that he was socialising at these clubs. Can you just tell us a little bit about what kind of activities he was undertaking?
He was doing drama, dance, music, bowling, snooker, lots of cooking activities, day outings, all sorts of different things, but with a group of people who also had learning disabilities.
That's what I was going to ask. Were the people that were all the attendees of the club, were they, maybe not all, obviously to a degree or one degree or another, they had learning difficulties?
Everybody in a particular club that he goes to has a learning disability of some sort.
And were the attendees, you say that your son went to this one 4 mornings a week, were there other people that went regularly that he formed relationships with, friendships with? Yes,
not outside because we don't really do that much, but within the place, yes, it was their lifeline to be themselves and to be respected. And the real good bonds between people.
Is consistency of activities and socialising more important to your son, given his conditions, than it might be to other people?
Yes, totally.
Right, Mr. Dunlop, I think we're ready to go again.
Thank you, my lord. I think where we were, that we were talking about the activities that your youngest son attended and how they were important to him, the consistency of them. Now, you tell us in paragraph 17 that your son also attended a dance group once a week before the pandemic. And in terms of a typical weekend for your youngest son before the pandemic, what would your youngest son have done during the weekend prior to the pandemic?
Well, Saturday was always a kind of family day, going round and seeing sisters, brothers, mothers, different things like that. So it would just be a kind of day, and we'd probably have a meal out somewhere.
Out and about then?
Out and about, absolutely, yeah.
And you tell us at paragraph 21 that your youngest son received 4 weeks of respite on a 12-month period, and this allowed you to recharge your own batteries. And that respite, am I correct, you're talking about that before the pandemic?
Yes.
Yeah. And at paragraph 22, you tell us about the type of respite holidays that your youngest son enjoyed and the type of activities he undertook. And I think, am I correct that respite offered you said, that an opportunity to recharge your batteries. So was respite important to you?
Now, Mr. Lapp, I'm sorry for that, Dinley. We had a power cut out down here.
Thank you. Good morning again, ma'am. I've got to go through still a few more questions for you. You tell us in your statement from paragraph 28 about the impacts of the pandemic on your son, including the activities he enjoyed all stopping suddenly, including the morning clubs that we were talking about earlier this morning. And you say at paragraph 30 of your statement that your son thought that you were punishing him, and I presume that must have been heartbreaking to hear that your son thought that you were punishing him. Am I correct?
Yes, it was.
Okay.
Heartbreaking.
And you tell us at paragraph 32 that the independent dance sessions, because you told us that you went to these dance sessions, went online, and that your son joined other activities online, such as bingo. And you also tell us that you had an old iPad that didn't work well, and that was really all that your son was able to use in order to keep in contact. Is that correct?
Yes, I don't have a smart TV, so everything was having to be done on the iPad.
Okay.
Yeah.
Okay.
Difficult.
And you talk about in paragraph 37, you tell us that the government did not provide for the learning disabled or carers, and you tell us your views on that. At paragraph 40, you go on to say that the structure was removed from your son's life. And am I correct that, given your son's medical conditions, that structure is very important to him? Structure
is absolutely paramount, particularly with people on the autistic spectrum. Yeah.
And you tell us at paragraph 42 that communication from social work and cross-reach was poor. Again, without naming any names, and I'm asking you just about social work and cross-reach. What was it about social work and cross-reach? What aspect of the communication was poor?
Cross-reach didn't know what they were doing in terms of what they were allowed to do, what social work would allow them to do, and they're providing a service with social work's blessing. So they couldn't really give me any information, and there was no way of getting a social worker to get back to you within maybe 4 or 5 days if you tried to contact them.
Okay. Thank you. And you tell us at paragraph 43 that when respite recommenced in August 2021, that your son was not permitted to attend as he lived in a different authority. And could I just on a yes and no basis, was there any respite in your authority that your son could have gone to?
It was almost impossible, okay, because everybody was asking for respite and everybody was calling the emergency social work. So Enable might have been able to offer 2 days, but the only other option was a care home, and that wasn't for people in a dementia unit. Don't think that was appropriate for my youngest son.
Okay. Thank you. And you then go on to discuss shielding, and you tell us that your youngest son was first told he should be shielding. He was first told he should be shielding 6 months after the start of the pandemic. And am I correct that the reason for your son requiring to shield was that essentially he suffers from Down syndrome, and there was pressure put on the Scottish Government by various Down syndrome's charities? Is that correct?
That's correct.
Okay. And you tell us at paragraph 48 that you spoke to City of Glasgow Council hundreds of times, and I think you've explained that it was difficult to get through to social work. Am I correct? Is that what you?
Yes. Yes, very difficult, okay, and getting a different person, and I think the people on the end of the phone were getting frustrated because they couldn't do anything either. So it was just not good.
Okay. And at paragraphs 57 to 59, you explained to us in your statement that your youngest son got frustrated due to the lack of respite and the failure of people to socially distance when you were out. And I take it, is that something, again, develop the answer if you want, but you can answer it yes or no. Is that something that did your son not really understand what was happening?
On one level, he understood because he was obsessed with Nicola Sturgeon's conferences every day. But on the other hand, he wanted to see his friends, so I didn't really understand.
And he couldn't do that, and that upset him, am I correct?
It really upset him.
Okay. And we'll come on to that. I think you discussed that later in your statement. We'll come on to that very shortly. From paragraph 60 to 73, you discuss the reopening of services such as respite and the morning classes that your youngest son attended, but you tell us that the 2-year break had an impact on him, and you tell us now, at paragraph 64, you tell us now that he's happy to sit on his own in front of a computer, and that's even when he's away in respite. In terms of respite's been open for a period of time, have you seen an improvement in your youngest son over the past couple of years, or are we now plateaued in terms of where he is?
My son was in respite just a week ago, and it's the first time that he has participated in activities out with the building. Similarly, I would say just in the last few weeks, he's started to go out again from the building at Crossreach. I don't allow any electronic devices to go with him because of the natural isolation of being on one.
Can I ask a question? We've obviously been talking about your youngest son. There's other children or adults with learning difficulties that attend these classes. From speaking to other parents, is the experience that you've had with your youngest son, is that mirrored by other parents? Have they said that their children have become, introverted as a result of the period where they were unable to undertake the activities? Is that something you've heard other people complain about?
Absolutely, and I think there are some people that have never returned to the dance company at all, who were extremely talented. So it's really sad that the break for them gave them an option.
Thank you. And at paragraph 65, you tell us your son is more clingy now and he's content not to leave the house. You also tell us it's harder to get him out of bed, and he will say he's sick. And when he says he's sick, is that not genuine? Is that an attempt to essentially stay in the house?
Generally, it is. I mean, I have to go through a whole lot of checks, but on the whole, when my youngest son doesn't fancy doing something, he might tell you 2 days before that he's going to be sick on the day he's going to do it. So It's pretty obvious that it's about not wanting to go out.
And can I ask you about yourself? You tell us at paragraph 73, and I've just got a couple more questions for you, that you've not fully recovered. So putting your youngest son to one side, in what respects have you not fully recovered?
I'm 65, therefore I'm not my first flush of youth, and I'm exhausted still with it. I've been treated for depression and an ADHD diagnosis very recently. My dad died during COVID as well, and so we had to have a funeral with 12 people. So all these things have kind of played on my mental health.
And do the medical professionals attribute your mental health problems to the pandemic?
The isolation, yes, definitely, because it's much more difficult. I find it more difficult myself to go back out into the community now than I used to.
Thank you. And finally, in your statement, you provide us with the hopes for the inquiry, and maybe if I can just summarise those. Firstly, you tell us that carers should be treated as key workers. Secondly, you tell us that facilities for the learning disabled should remain open with restrictions. And thirdly, if I'm summarising them correctly, you say that communication from social work services requires to be better. Is that a fair summary of what your hopes are?
Yes, very much so.
Thank you. just before I thank you for your time today, is there anything else you would like to say to the inquiry? And given we're in the last minute, I encourage you not to use your youngest son's name if possible. But is there anything else you wish to convey to the inquiry?
No, it was hard, I think, to have NHS workers getting discounts at shops who were on salaries and unpaid carers not. It sounds really petty, but it was really upsetting at the time. Really upsetting. But apart from that, I apologise for several times using my youngest son's name and making.
I'm fortunate enough to have more than one boy as well, and I know how difficult it is when you do use names. So certainly, as far as I'm concerned, I'm sure His Lordship echoes my thoughts that it's entirely natural, and I think His Lordship mentioned that earlier. So there's absolutely no need to apologise. My Lord, unless there's anything further, there's nothing further.
Not at all, Mrs. Dunlop. And Madam, I echo exactly what Mrs. Dunlop said. You've got no need to be apologising to us for that. Thank you for your evidence. I'm very grateful. 11 o'clock, Mr. Dunlop?
Yes, that, I hope the witness should be here. The witness is travelling.
The witness is here.
Oh, it's up. You're more in the know than I am. So, yes, 11 o'clock's perfect.
I have ways of knowing.
Perfect. Thank you, Mud.
Thanks. Good. Good morning again, Mrs. Dunlop, and
Good
good morning,
morning.
Ms. Small.
The next witness is Dr. Small, and just for the benefit of your notes, Dr. Small's witness statement is referenced SCI WT 0475 and 5 zeros, then a 1.
Very good, thank you. And sorry, Dr. Small, I didn't appreciate you were a doctor.
Dr. Small, can you provide us with your full name, please?
Amy Small.
Thank you. And you've provided us with a statement that I've just read the reference out to His Lordship. In terms of preparing for today, when you've been looking over the statement, have you noticed any typos or errors that you feel that you should bring to the attention of the inquiry?
There's just 3 dates that are out by a week from when I got sick.
Do you want to tell us where those are, just for the benefits of the recording?
Unfortunately, I didn't write down the paragraphs with me here, but
Oh,
I
well,
can
no,
provide that afterwards.
No, that's fine. But it's just dates.
Yeah.
And perhaps I wonder if you look at paragraphs 61 and 62 first.
Yeah, it's those dates.
And when you say it's those dates, can we look at the first date on the 17th April 2020? Do you know what date that should be?
That should be the 10th.
It should be the 10th. And does that mean that the one in the next paragraph should be the 11th?
Yes.
And if we look at paragraph 65, we see the 20th, and that should be the
13th.
13th.
Minus
Thank you.
7, yes.
No, I was trying to do it in my head as well. It's not easy when you're giving evidence or asking questions. Thank you. And as I said, you've provided this statement, and we see in paragraph 1 of your statement that you're a qualified general practitioner and also hold the position of clinical advisor to the charity Chest and Heart Stroke Scotland.
Yes.
And just looking at the overview of your career, in paragraph 6 to 15, you narrate some of your career history and essentially the route you came to becoming a GP working in Preston Pans, East Lothian. Is that a fair summary of it, doing it swiftly?
Yes.
Thank you. And at paragraph 16 of your statement, you say that in November 2020, you could see what was happening in China and what would happen next if it comes to Scotland. And you tell us in 17 that there was no long-term planning in general practice, and that within one weekend the doors were shut and everything was being done by phone. In terms of planning, are you of the opinion that pre-pandemic planning for a GP practice better planning should have taken place? And if so, what do you have in mind?
I think back to the swine flu pandemic, actually. And so we'd had some practice in the sense of we'd lived through a little bit of that. But because swine flu never came to fruition, we never had the fallout, I think, that we were expecting. There was probably a degree of blasé-ness in the early days of thinking, well, hopefully this will never happen. Everyone was very worried about swine flu, so, will this happen again? So what would I want for the future? I mean, I think it took us some weeks to gather, and a lot of that was just learnt from each other.
And we see each other fellow GPs in the practice or in the wider community?
Together, within the practice and in the wider community, I set up a WhatsApp group in East Lothian for all my colleagues to join in, so we could share things that we'd read or learnt, or share any official documents that were coming through. And it did take some time for us to create, for example, the Red Room. So every GP practice learnt that we were to have one area, a room where we would see people that potentially had COVID. But I remember doing that then in April, and of course we had locked down in March. So that had taken some time for us to get to that point. And I think in the future, we would know exactly what to do in advance, and that had never been discussed.
Out of interest, you talk about the Red Room, and we've heard of that from other witnesses. Did the concept of a Red Room, did that mean something to you before the pandemic? No. Or was that something that you became aware? And how did you become aware of the need, the requirement to create a Red Room?
I think that was through fellow colleagues and WhatsApp groups and things that people had learnt from elsewhere.
So is that essentially ad hoc sharing good practice?
Yes.
And you move on to discuss in your statement the difference between Scotland and England in relation to being able to call 111 for medical appointments. Can you tell us a little bit more of what the difference was in England if you wanted to contact your GP, and what the difference in Scotland was?
So from my recollection, calls to general practice were fielded by 111 in England in those earlier days, which we didn't have access to here. So if you thought you might have COVID or an illness related to it, you phoned 111, and then there was a sort of call handling system that went on from that. Whereas in Scotland, you phoned the GP. So that first Monday of lockdown was just insane, because everyone who had sneezed once, of course, understandably had panicked and thought they had COVID, and we were having to field all of those calls in the practice with no additional support. And I remember just feeling a little bit aggrieved that we didn't have any additional support, which it felt like England had that we didn't.
Okay. And in terms of the volume, you know, in the first few days, I mean, can you put that into numbers, or is that something you wouldn't know? I'm not trying. It's not in your statement, so it's not memory test.
I cannot recall, but it was huge.
Okay. You go on to tell us in paragraph 22 that patients were being seen in gazebos in the practice car park. And was that big? I mean, I can appreciate the reasons for having them out. To obviously, the fresh air. Well, I presume the reason is the air circulating. It might be suggested that by some witnesses that appointments could be replaced by, you know, telephone or remote consultations by iPad. What was the benefit of being able to see the patients in the, you know, in person, albeit in the car park?
There are some people you just have to examine. You have to check that they can breathe, that their oxygen's okay, that their temperature's okay. And it wasn't all just COVID as well. You know, people were sick for other reasons. So there are always times when you have to see someone face to face. I mean, we did change how we practice medicine and general practice, and there is a lot that we discovered we could do over the phone, you know, and that was beneficial to patients as well. Not everyone wants to take the day off to go and see the GP. So there were things that benefited, but there are simply times you have to examine people to see how sick they are and whether they needed treatment or admission to hospital.
Moving on to paragraph 26, you tell us that after a few days at the beginning of the pandemic, patients stopped phoning, and that patients felt that you really had to be sick to see your doctor. I'm just wondering, in terms of services that were being provided by the practice, you know, in terms of antenatal screening for cancers and serious disease, were those taking place in 2020 after the pandemic?
So I got sick relatively early on, so I can't give timelines for everything as I was off, but certainly for the beginning of the pandemic, we stopped all screening. All protocols were looked at differently. For example, people who were on a medication called warfarin that thins your blood that you might need to take to prevent stroke, we were appropriate. We actually switched those patients onto a different medication that didn't need regular monitoring. So they didn't have to go and have regular blood tests, which would mean they didn't have to come into contact with healthcare workers. So there was a whole swathe of things that we did differently. We found out what contraceptives actually could be used for longer than their original licenses. That was done across medicine in general. Everything was done to try to stop people coming in, to try to protect them and us.
And was that being done in an individual GP practice, or was that something that was being filtered down from the Royal College or the BMA? Or
we got guidance. We got some guidance from National Services Scotland. We got some guidance published by various different bodies, depending on what it was, and some was done through just mutual discussions with colleagues. You know, what could we do differently? What could we do as individual clinicians to make this better?
Okay, and I think.
Can I ask a question? I understand that, very clear evidence, if I may say so, Doctor. Could all that have been done in advance and in a centralised fashion as well, as the obvious mentioned?
It's a really good question if it could have been done in advance. Of course, I suspect all these things could have been done in advance if we'd had appropriate pandemic planning.
That's the point, isn't it?
Yes. So I think now we've learnt a lot from this, and I would hope that for future pandemics, and I also think we brought a lot of what we learnt into our everyday practice, which has revolutionised some of what we do for the better.
For example, it wouldn't have been beyond the wit and wisdom of, I'm going to say man, but probably doctors is a better way of putting it, but the wit and wisdom of appropriate people to have sat down with a blank sheet of paper and said, right, let us assume we're going to have a pneumonic virus. What things could we do of the sort that you've described that we could have a ready-made plan set to run, and you could do the same for an enteric virus and so forth and so on. Is that correct?
Yeah, and I certainly think that would have taken an awful lot of stress away had we had that planning.
Yeah. No doubt a lot of effort, but it could have been done.
Yes.
Yes, thank you. Sorry, Mr. Dunlop.
No, not at all. Thank you, my lord. You go on at paragraph 28 to then your chapter of evidence on do not attempt CPR. And in paragraphs 28 to 41, you discuss having to phone patients who are vulnerable to COVID and asking whether they wanted to be resuscitated or not. And you tell us that in some cases it was not appropriate to do this by phone. The point you make at paragraph 41 is that the decisions made in relation to do not resuscitate were made in the context of COVID at the beginning of the pandemic. Do you know if GPs have since reviewed the wishes of those patients, and now that there's been a vaccine rollout and I suppose the threat of catching COVID isn't quite as harsh as it was at the outset of the pandemic?
I honestly don't know what's officially been done, as I'm no longer a partner and I'm not involved in the planning of looking after patients at that level. I certainly would hope that some of these things have been reviewed at a practice level.
You said you didn't know what officially had been done, which suggested you may have something that you can offer in terms of. Do you know do you have a?
I mean, if it was my practice and I'd been a partner somewhere, I probably would have gone back and looked through all the anticipatory care plans that we had written at the time, and gone back and reviewed and updated those. But it's a big piece of work.
You then go on to discuss protective equipment at paragraph 42 through to 59. We've heard from witnesses who were carers, and I think you echo their evidence at paragraph 45 when you say it took too long to ensure that carers had access to PPE. You also say it wasn't the right PPE. Why do you say that? What was wrong with it?
The PPE that we got?
Well, the PPE, I think you deal with carers as well as, because I think you talk about going out and having seen carers doing house visits. What in particular was it about carers that wasn't satisfactory?
Well, initially they had no PPE at all. We were given the surgical masks that were rather large, and dinner lady plastic aprons, and a visor if we were lucky, and gloves for an airborne virus, which was not appropriate for us, let alone carers. So if you are a vulnerable person, potentially on immunosuppressant medication, and you're having 4 different carers a day come into your house, and they're also visiting lots of other houses, and they are all either not wearing PPE because they weren't given any for quite some time, or they're not wearing the appropriate PPE when they had it, i.e. at least FFP2, if not FFP3, they were potentially spreading COVID from house to vulnerable people who otherwise wouldn't have had it because they were sitting in their homes on their own.
Thank you. And you mentioned the rather large surgical masks, and I think you deal with that in your statement. You say at paragraph 48 that the masks you were supplied with didn't fit properly. And you also mentioned that people who were exposed to aerosol generating procedures could get FFP3 masks, but breathing it itself, is that, and am I correct that your evidence is that GPs should have been provided with these masks? Absolutely.
I mean, there was this constant battle that public health had said that it had to be an aerosol generating procedure, i.e. sticking a tube down someone's throat or using an endoscopy or something that would make someone, cough in your, through this procedure. But merely breathing is an aerosol generating procedure. And so therefore anyone who's coming into contact with someone who's potentially ill should have access to that if you're in a healthcare setting. And still, months down the line, when I was working in COVID units, I still didn't have access to that. And I still wouldn't have access to that now. And so I feel, 4 years down the line, not much has changed there.
And you tell us in paragraph 46, just dealing with, I think it's masks. You say that the local community made personal protective equipment for the doctors in your surgery. Was that masks?
No, they made the visors.
They made the visors. And I don't know how to put this, but presumably that didn't offer you the same level of protection as professionally constructed or professionally manufactured PPE.
So the visors, I think, that the community made would have been the same as any visors you'd get anywhere. Frankly, they were fine. It's just that visors aren't PPE. I mean, they're not PPE. They're not protective for this sort of a virus, an airborne virus. So it was fantastic that they did that, and it certainly gave us some reassurance. But really, we know that what we needed was FFP3 ideally. And
dealing with FFP3, you've already told us about creating a WhatsApp group with other GPs in the area in East Lothian, and in paragraph 20 you talk about the discussing matters with the BMA. Was the issue of the FFP3 masks being raised at a higher level?
It was continuously raised at a higher level. I raised it personally, others raised it at the BMA, and still continue to raise it. There are still doctors who haven't got access to it in secondary care settings who should. What we've found is that women in particular, and Asian women in particular, have smaller faces, and it's harder for them to get masks that fit. And the problem is that each fitting takes half an hour for just 2 masks, and that's the only slot that you get. The hospital where I attended only had 7 masks in total, and I was told at the beginning when I tried to get a mask fitted that it was probably unlikely that they'd find one that would fit my face. This is a problem that a lot of women in particular and smaller women face, and I think other people with facial hair and other issues have also had problems and continue to have those problems. And general practice in particular didn't have access to any of that testing. In some regions, I believe in Tayside, they did do an outreach to primary care where they could go and get measured in the community and did measure up GPs, but that certainly didn't happen in the Lothian area and probably in the majority of Scotland.
And when you were giving your evidence there, you mentioned, you were talking about whether it was primary care or secondary care. Was there a difference in the availability of PPE depending on whether you were in primary care or in secondary care as a doctor?
In the sense that if you were in secondary care, A, you could go and get fitted on site usually, so it was there, you didn't have to travel to it, and B, more secondary care doctors would have been classed as doing aerosol generating procedures and therefore would have been eligible for at an earlier stage than primary care.
And you go on to tell us, I don't think we can discuss it in detail today, but unfortunately, we'll hear about you contracting long COVID, but you lost your job in late 2020, and then you secured locum work in a hospital, and you tell us in paragraphs 51 and 52 that was the point where you were fitted for an FFP3 mask. Is that? And before then, you hadn't had access to those masks?
No, so I got the job in the COVID assessment unit, and there it was standard for us again to wear the surgical masks and the plastic aprons and visors and gloves, and we didn't routinely get offered FFP3. I wrote to the team organising that unit and said, look, I really want access to FFP3, I'm just recovering, I really don't want to get COVID again. And they said, oh, well, you could go if you wanted and get fitted. So I had to arrange that in my own time. And as I said, I did this off my own back on a Wednesday morning. I went for one fitting, and the guy looked at me at the beginning and said, this is going to be tricky. And I quickly gave up after one session of that because it took half an hour each time. I was locuming, which was my only income, and it was over half an hour away from where I lived. So every time I was going to go and do that, I was therefore not having any income, and I was also ill still. So even the effort to get there to do that was taking away from me. So I actually never did get FFP3 fully fitted. I stopped after one session.
And had it been fully fitted, would that have been, I don't know, are you provided with a number of masks that are all fully fitted, or are there filters? How does it actually work?
So my understanding would be that you would have had one mask per session that you worked, and that would have been provided by the hospital. And so that would have only been it within that COVID assessment unit setting. I don't know what I would have done then going back into general practice where I was doing my other locum work, whether I would have had to have provided that myself. So at that stage, I just purchased FFP2, which I found was more appropriate than just surgical masks.
The question I suppose I was maybe badly putting was that, did you need to be fitted every time you got a new FFP3 mask?
No.
No.
So once they found, unless you grew a beard or something,
Right.
you could keep the same one.
And you move on in your statement at paragraph 60 to talk about long COVID. And you identify that you contracted COVID, and at paragraph 16 you say that, I'll go through the details relatively quickly. You tell us you were setting up the Red Room at the GP practice on 16th April, and you were setting that up with a nurse who had tested positive for COVID the following day. Is that correct?
Yes.
Yep. Then you tell us that you started to feel poorly, but that you took a test and the test was negative. In your statement, you tell us that 2 weeks later you were still feeling awful and had a temperature, and you went to the Western and tested negative again. Is that correct?
Yes.
And you describe a range of symptoms in your statement, including breathlessness, a fever, headaches. Am I correct that you were having all these symptoms and you were off work, but you were still testing negative? Is that correct?
Yes.
Yep. But nobody's ever suggested that you didn't have COVID?
No.
No.
I'm one of the lucky ones. I've been believed all the time by my healthcare professionals. In the earlier days, my belief is that the tests weren't that accurate. My understanding was that there was still a 20% false negative rate, and some data that came out at the time said that that was as high as 80% false negative if you didn't have a cough. In the early days, we were only eligible to be swabbed within the first, I believe, 48 hours of the illness, and I didn't develop the cough till day 6. And there was only a small window when those tests would remain positive. So I was tested before I had a cough, and then 2 weeks in when I'd been ill for too long, if you like. So because of all of the rest of my symptoms fitting very much with COVID, I was lucky that I was believed, but many other people with long COVID have had problems proving it.
Okay. And I think, without naming names, your husband also contracted COVID, and he was poorly for a lengthy period as well.
Yes.
Was it classified as long COVID by anybody professionally?
Yes, he also has a long COVID diagnosis.
Did he test negative or positive?
Also negative, because he was tested at the same time frame, actually even earlier, because it was on my day 2 and his day 1 of the illness.
Thank you. And at paragraph 86 of your statement, you mentioned reading an article in the British Medical Journal, the BMJ, in May 2020 about long COVID. And I think, sorry to put this into, I don't think I asked you, when was it that you started to suffer the symptoms? You talked about the Red Room on the 16th of April. Was it right at the beginning? Was it mid-April that you started to feel poorly?
So we set up the Red Room on the 9th. The 10th was, I think, a bank holiday Friday, and it was the Saturday that I started to feel unwell. And I just didn't get better. So a month in, I was pretty sure there was something going on.
And you were off work that full period?
Yes.
And just to put it into context, I think you went back in a phased return. We hear later. When was that?
So I tried to do 2 days in June. I was still having fever every day at that point, but I had been reassured by infectious diseases that I wasn't contagious at this point. It was something else causing the fever. So I tried 2 days, but those 2 days then made me very unwell, and I was in bed for about 10 days after that.
And turning back the clock a bit, when we look at paragraph 86, you say that you read this article in the BMJ in May 2020 about long COVID. What did you think when you read that article?
It was a real light bulb moment for me. I read this and I remember saying to my husband, look, it's not just us, there's other people out there with this. And it was about that time that stuff started to come onto social media. And I looked at Twitter and saw more and more people sort of talking about this phenomenon known as long COVID. And then we had a doctor's long COVID group that popped up onto Facebook. And it was really through peer support that I found out more and more. And from a community of people who'd had ME for a long time, I got a lot of information from them as well.
Because I think you deal with, talking about ME, you deal with that at, I think it's paragraph 91, where you tell us that you, as you've already indicated, tried to return to work as a GP in early June. And then in paragraph 98, you state that you started to think you had ME, and that you saw a nutritionist, an osteopath, and read up on your symptoms. We see also in paragraph 107 that you had a full body CT and a heart scan. I mean, over what period was all these tests?
So I initially saw infectious diseases in May 2020, where they just did some blood tests and another swab at that point. And they told me that they would contact me in August, and it was then in August that they were shocked that I still had fever and I hadn't been back in touch with them. I was just waiting for them to contact me. And so it was then September that I had the echo scan of my heart and the CT scan. So the more of those tests happened then at that point, because really long COVID is a diagnosis of exclusion. So you need to make sure there's nothing else causing the fever, something like lymphoma or another disease. So that was their main thing, was to rule out anything else that could be causing my symptoms.
And was everything else ruled out?
Everything else was ruled out. I mean, I ended up with this diagnosis of postural orthostatic tachycardic syndrome, which you may or may not have heard about from others with long COVID. But
We have heard about it,
yeah. So like many with long COVID, I ended up with that diagnosis, which I self-diagnosed, but managed to get support after that.
And I didn't ask you how you were before the pandemic and before you contracted long COVID. Were you a fit, healthy person?
Yes, we used to run 5K 3 times a week. We did weekly Pilates together, my husband and I. We did, the daily exercise that we were all encouraged to do at the beginning of lockdown. I've got a gazillion selfies of us up various hills in Edinburgh with the children. So yes, I was fit and healthy.
And without jumping forward too much, but I mean, how are you now? Are you recovered? Do you still have some symptoms?
I'm very fortunate that I'm well enough to be able to work full time. I don't know that my body will ever be what it was pre-COVID.
And you say well enough, that suggests to me, maybe I'm reading too much into it, that you're still suffering some
Every time my children get a cold, I get fever. I become much more unwell with illnesses. I had COVID for the 3rd time in September, and I was floored for 2 weeks, and it took me till December to get back on a bike again. That wouldn't have happened pre-COVID.
And at paragraph 147, you tell us that you're now well enough to work. And what are you working as now? Sorry, I should have asked.
So 3 days a week, I'm clinical advisor to Chest, Heart and Stroke Scotland. And 2 days a week, I'm a locum GP.
And I think you were in the East Lothian area. I think, are you now working in England?
Yes, I now live in Sheffield.
You also tell us at paragraph 147 that you've become aware of other doctors who've also been unable to continue working in medicine full-time, at least, due to long COVID. Can you give us an impression of the magnitude of that issue?
So, actually, the BMA did a survey back in 2023 last year, which 600 doctors responded to. And of that, 1 in 5 doctors reported that they couldn't work. 48% experienced a loss of earnings. And I had to crowdfund for a colleague who's a GP who was eating out of a food bank. And I found that eating your Christmas dinner out of a food bank was rather depressing. And a group of us got together to support her, to help her. And
the BMA survey, do you have more details of that, or are you able to provide the inquiry with more details?
I am. I can definitely provide the report and the journal article that was published alongside that.
And you tell us in paragraph 154 that various countries such as Belgium, Spain and Canada have recognised COVID as an occupational illness. Am I correct that you're advocating that that's something that the UK or Scotland should be doing as well, and why?
So I wrote a motion to the BMA annual representative meeting back in September 2021 calling for for COVID to be recognised as an occupational illness. Doctors in Canada, Spain, Belgium, other key workers have already not only had it recognised but had compensation. Those that died, those that have been severely disabled as a consequence and unable to work, have had that recognised and been compensated accordingly. And I'm still really disappointed that we have not come further forward, some 4 years later, with that. for a bunch of doctors that got sick at work during a pandemic. In that survey that I mentioned earlier, 77% of people in that survey said that they believed they caught COVID in the workplace. And only 11% had access to FFP2 and only 16% had access to FFP3. So I think it's absolutely just that this is an occupational illness and that doctors who have been disabled and are unable to make a living are justly recognised and compensated for that. And not just doctors, I mean all health and social care workers and other key workers who have suffered.
All persons who have contracted it in the workplace,
Yeah.
essentially. Moving on to your own, and I appreciate there's not one size fits all, but you tell us, you go on to discuss the impact and your diagnosis and treatment, and you tell us in paragraph 160 that you asked to be prescribed beta blockers, and I think it was a particular type of beta blockers, and you identify in your statement, and you say that was very effective in treating your long COVID symptoms. I mean, what was it that caused you to conclude you were almost, I don't want to suggest it was a science experiment, but it seems as if you were trying to kind of work out what might help you. How did you go about that?
So I'd been reading all that time that I was ill about COVID and about long COVID, and I've been hearing more and more about this group of disorders called dysautonomia, where your temperature control is out, your heart rate's up, and your respiratory rate is up, all because that part of your brain isn't functioning properly. And it was becoming evident, as we know now, that COVID is a multi-system disease. Initially we thought it was just a lung disease, but we now know it affects every part, including our brain. And because I still had fever in September, every single day I'd had fever since April, I figured I probably fell under this group, and that I'd learned through social media. I had a difficult meeting with my partners where I suspected I was going to lose my job, and I had some out-of-date propranolol that I'd been prescribed for when my father was dying, and I was anxious about his death at the time, and I thought, I'm just going to take this to see if I can get through the meeting. And it was at that point that, regardless of what happened in the meeting, I realised that I could walk up the stairs without stopping. And I hadn't managed to do that in 4 or 5 months. I lived in a double upper, and it was always that difficult bit, and always the dread of going up the stairs that was a difficulty. And I'd noticed that when I brushed my teeth, I was standing up and my heart rate was 110, but my resting heart rate was 58.
Is that because you had a watch?
Yeah, and I thought, oh, that's odd. It shouldn't be 110 just because I'm standing up. And when I walked up the stairs, so I started to then look at my watch more. So when I walked up the stairs, it was 145. And I was someone who was able to run 5K 3 times a week prior to this, so I knew that this was an abnormal response. And so I phoned my GP, who was really supportive, and I just said, look, I think I've got POTS, and could I try a beta blocker? And that made all the difference. Within 2 weeks of starting that, I could keep up with my incredibly slow 3-year-old, which was something I hadn't been able to do for a long time.
And just without naming names, your husband, who you said also suffered from long COVID, did he benefit from a similar treatment? Or?
So latterly, he certainly, unfortunately, as we got COVID again in September, he's had a big relapse since then, like many others, and has struggled with that. But he certainly has had a similar diagnosis and has had treatment appropriately to help support him.
And you also go on to discuss in your statement that you saw, I think we mentioned earlier, that you saw a nutritionist. Did you change your diet, and did that have an effect?
So, yeah, in those early days, I mean, I was very fortunate that I had the means to see these people because, it was an expensive venture, not only for the appointments, but for all the supplements and food that we bought as a consequence. But one of the most important things I learnt from her was to allow my body to rest. Therefore, no alcohol, no caffeine, no sugar. That was the biggest difference, was cutting out sugar to stop the body going through these peaks and troughs of stress internally. No, and then we also cut out dairy and gluten. I've never been so healthy in my diet, and we did that for some months, and it did make a degree of difference. There certainly was benefit from that, but it didn't cure it.
Okay. You talked about having the means to be able to do that. Now, if individuals were suffering from long COVID presently in 2024, and I appreciate you're practicing in England, so it's maybe unfair to ask you this question, but do you know if nutritional advice and similar would be available to long COVID?
So I certainly, I mean, in my own practice, I talk patients through it, and I do say to them that they may consider giving up you know, the big vices, the caffeine, the sugar, the main things. But I'm also very conscious that the vast majority of people can't afford to do these things. Food's really expensive. Eating healthily is really expensive. And I can simply give them a guidance, but many aren't as fortunate as I am.
Okay. And I'll maybe come on to what treatment is available to people who are suffering from long COVID. But you say at paragraph 169 that you've chatted to, and I hope I'm quoting you correctly, long COVID doctors whose patients with long COVID have suffered strokes, MS and breast cancer. I wonder if I could ask firstly, what is a long COVID doctor?
Well, that's a good question, actually. As yet, in Scotland, we are somewhat behind in our treatment of long COVID and development of long COVID services compared to England. So in England, they set up services much more quickly. And there are some long COVID services in England who have employed doctors specifically to manage the clinical aspects of long COVID. So the vast majority of long COVID services in Scotland are still rehabilitation services, and they don't have a doctor attached to their team who can diagnose and prescribe. So the diagnosis has to be usually made by the GP, and then the patient is passed over to that team to help with pacing, advice, fatigue management, etc. So long COVID doctors are ones who predominantly exist in England and other countries, who have developed an expertise through the clinics that they work in, or those who have self-interest. So there are doctors, as we know, in Scotland who've given evidence here, who have developed an interest in long COVID and have prescribed and treated patients well accordingly.
Could I maybe just probe you a bit more about the difference? So in Scotland, you said it was a rehabilitation service only, and that there wasn't a qualified doctor, I think is what you said. So what is a rehabilitation service? What is it you can currently get in Scotland if you're suffering?
So the funding went down to health board level, so it's dependent on the health board that you're in. There are a couple of health boards that do have doctors that work within them, but the vast majority don't. So the rehabilitation service will be that you will see potentially an occupational therapist who can help you with your day-to-day tasks, a physiotherapist who can help you, again, with your day-to-day symptoms. You may be lucky enough to see a psychologist who can manage the mental health fallout of having a chronic disease, and also other people who can help you with navigating the benefit system, etc. But the vast majority of long COVID clinics in Scotland don't have a doctor attached to them.
Okay. And in England, and maybe I'm misunderstanding position, can you go to your GP and ask to be referred to a long COVID doctor?
The vast majority of places, yes, you can. You'd be referred to a long COVID clinic.
Sorry.
And some of them may or may not have doctors, but more of them have doctors than they do in Scotland.
Okay. And what would happen in a long COVID clinic if you were referred there? Maybe that's, it all depends on the patient, but is there a treatment regime or particular tests that they undergo? Or is there...
Well, it's an entire postcode lottery.
Is it?
It's an entire postcode lottery, so it really depends on where you live, who you see in the first instance, whether they believe that you have this illness, how much they know about it, and then it will then go on to who you can be referred into, and then it'll depend on what service is available locally to you.
Okay. So am I right that whilst England's more ahead of Scotland, there's still not a perfect service in England either? Is that fair to say?
No, there is not. And again, the funding is now being rejigged, so it's no longer allocated purely to long COVID, and so things are changing in England as well now. I think that's one of the big concerns. Is it's almost like we're pretending that it's all finished now. COVID's finished, and no one's testing anymore, and therefore it's all going to go away, isn't it? And that's how it feels.
When I originally asked you the questions when we were looking at paragraph 169, you mentioned the long COVID doctors whose patients had suffered strokes, MS and breast cancer. Were those doctors suggesting that there was a kind of causal link to the conditions and long COVID? No,
I think there have been some cases where it's, these other conditions have been missed. They could have had both. They could have had long COVID and those, but then I think there's other patients who potentially had lymphoma, for example, that produces fever, and someone went, oh, well, I can't see anything else that's wrong with you, so let's call it long COVID, but actually they've then not been investigated further. So I think that is the big concern with long COVID from a clinician perspective, is that the diagnostic criteria is one symptom for 12 weeks or longer. So it's very vague. We don't have a set of symptoms yet that's still, or a diagnostic criteria that's other than exclusion of other illness yet.
In paragraph 173 of your statement, and you talk about the Scottish Government funding, and you seem to be, maybe you're not, but it seems to be a criticism of the funding of long COVID. What do you say should be done?
I mean, look, we've got 180,000 people in Scotland living with long COVID. If we look at, I mean, I've long now begun to understand that I feel our government doesn't particularly care about people, but it certainly cares about economics. If we look at the economic impact of long COVID and the number of people that are off sick, the number of people that are unable to work, the number of people claiming benefits, to me it's a no-brainer that we invest up front to treat these people and provide decent services much earlier on in a patient's experience and illness, to make sure that they don't get prolonged illness and disability, because there's thousands of disabled people now as a consequence of this who have not been seen early enough, who have not been treated, and who still aren't treated, and it's not acceptable.
And I mean, on that point, you discuss in your statement, I think it's down at paragraph 177 and 178, you talk about a talk that was organised by the Scottish Government in which various medical professionals were dismissive of long COVID. In your opinion, you've maybe answered this to a certain extent because you've talked about people thinking that it's all over, but is it a question, is the medical profession taking long COVID seriously, in your opinion?
Some are, some aren't. I think it's improving, and it's a sad state, a sort of sad fact that it takes a lot of doctors to get sick with something to make people understand and realise that it really is a thing. There are people with ME who call themselves the missing millions because they've had that diagnosis, they've been put in a box and they've locked the key and we've thrown the key away. And those people have been, for years, banging the drum to say, listen to us, we're ill, and not very much has been done for them. You've now had a pandemic, and as a consequence, a huge percentage of healthcare workers have got sick, and a huge percentage of those people are now turning around going, oh, it really is a thing, and I didn't really get it before, but I get it now. And so if one good thing has come from this is the fact that maybe actually a lot more people are going to be taken seriously and learnt. But unfortunately, there are still those that don't really get it. They don't really believe it. They think that there's probably more psychological aspects that's making us ill than true pathology. And I don't know that we'll ever really change those doctors' minds.
I was going to say, where do we need to, what needs to be changed? At what level does it need to be changed? Is it at the GP level? Is it a higher level? Is it a government level? Where's the...
I mean, public health need to talk more about this. We're not talking about this. And we're certainly not talking about it now, because now we're not testing. So now we're not even testing for COVID. As a doctor, I'm now finding it very hard to diagnose long COVID. I can diagnose a post-viral illness, but I can't hand on my heart for some people say it's COVID because we simply don't know. And those patients aren't maybe ready to admit that it was COVID that they had. So yes, we need to, right from the top, from public health, all the way down to medical schools, and what we teach about ME. I never learned anything about, post-viral illness at medical school, and I certainly didn't learn about it in my GP training. It's something I learned from patients and on the job.
And what do you know what's been done in England, essentially, to improve? You said it was a postcode lottery, I think, to use your own words. Are there changes in England that Scotland could learn from?
So they are creating a network for doctors, or not just clinicians working with long COVID, a sort of expert network, which is a start. And there's also some discussion about potentially creating almost like a certification for GP surgeries to become COVID-friendly, long COVID-friendly surgeries, so that GPs could do and practices could go through some training and be accredited as a long COVID friendly surgery, which hopefully would help raise the profile of the illness and reassure patients that when they go to that doctor's, they will be believed and understood and treated appropriately.
And can I ask, in relation to that last answer, Doctor, who they are in that they are creating? Is it health boards? Is it government? Is it the BMA?
It is a network of doctors that have been working within the long COVID clinic network in England, funded by NHS England. I don't know how the funding for this will come through. They are working jointly with the RCGP, I believe, at some point in the near future to look at this.
And I take it that we have some researchers and so forth. I take it that if we have a look, we will be able to find documentation from NHS England and the other bodies that you mentioned in your evidence a minute ago that will assist us in looking at this matter.
Yes, I recently attended a conference in Birmingham where much of this was discussed and certainly can provide the appropriate contact if needed.
If you could provide the contacts to Mr. Dunlop, will tell you who, it'll certainly save us a lot of work. Thank you very much indeed. You could do that, Mr. Dunlop, will you?
Yes, absolutely. We'll do that at the end of the evidence, which should only be another 10 minutes or so at the most. In terms of, you move on to the lessons to be learnt in your statement, and you have a chapter of that. And just maybe if I could just run through some of those relatively quickly and just see if I understand what you're saying correctly. In paragraph 198, you identify that in England and Wales, one parent had to be a key worker, only one parent had to be a key worker to have childcare support, whereas in Scotland, it was it two?
Yeah, certainly in the first lockdown, it was two.
And secondly, am I correct that you're saying it was wrong to tell people to stay at home to protect the NHS, and that essentially, I think this is a paragraph 200, you're saying that sick people should have been allowed or encouraged, I think is almost what you say, to see a doctor and go to surgery, is that?
Well, not just to surgery, but to hospital if needed. I mean, the number of people who, you know, I've talked with colleagues with long COVID who weren't sure they were going to wake up the next day, who wrote goodbye letters to their children, who should have been in hospital. We sat there with oxygen sats probes on our fingers and watched our oxygen plummet into the 80s.
You say we, that was you and your husband?
Me and my husband. That's not normal. And had I seen them in any, had I been my patient in any other time, and I'd come in to see me, I would have, you know, called an ambulance and said, you need to be in hospital. I think a lot of people became very sick and disabled as a consequence of staying at home to protect the NHS, and I think that mantra was wrong.
You then go on to say that there needs to be more research and funded treatment of long COVID, and I think we've discussed that earlier today. You then go on to say that the medical profession should be careful not to diagnose or label long COVID as ME. You deal with that in paragraph 207, and why do you say that?
It's more a concern that if we too quickly lump the two together, for those that haven't caught up yet with the pathology and haven't caught up with the latest, that again, we are going to fall into the missing millions. So that's not to say that people with ME are any less ill or valued than people with long COVID. It's that I want them to be brought up to us rather than us to be locked away with them.
And then you, as a general point, say that on a positive note, that newer ways of working have been discovered which enable people to free up time, paragraph 211. You say on a negative note, more people, including children, have become carers. And I wouldn't dwell on that because we've heard a lot of evidence from carers. But I take it that's something you've seen in your GP practice, or your practice as a doctor, sorry.
Yeah, I mean, the fallout of this entire pandemic from the psychological aspects of how children and young people have been affected and the elderly is huge. And I think we will see the ramification of that for years to come. And I think all the young people looking after their ill parents with long COVID, for example, that is going to go on for decades.
You mentioned further lessons, but have I picked up the main ones, or is there anything? I suppose this is an opportunity. If there's anything, because I'm almost at the finished my questioning. I was just wondering if there's anything else that you would like to add before I thank you for your time this morning.
I think it's, yeah, I mean, it's just emphasising the fact that the disability caused by long COVID, and that we need to recognise that, and ensure that does, you know, we move forward with that. But I think we have covered all the other points.
Thank you. My Lord, I don't have any further questions for Dr. Small. I appreciate I'm slightly ahead of time, but that's my questioning.
Thank you, Mr. Dunlop. And Dr. Small, thank you very much. That was very stimulating. I'm very grateful for your evidence. Now, Mr. Dunlop, we're not due to start the next witness until 1:30, I don't think. I've got no idea on this occasion where the other witness is, or whether the witness is likely to be here early.
I think the next witness is Dr. Cunningham's based in the Isle of Lewis. I can certainly make inquiries to see. I wonder, a lot of...
Well, you can... I'm perfectly happy, I'll just adjourn now, but if it's possible to have Dr. Cunningham earlier, then I'm perfectly amenable to do that. And it's 11:51 now, so any time really from 1 o'clock onwards, we could have Dr. Cunningham. And if you just get my PA to text me, if that's possible to do, I'm happy.
Absolutely.
So to do.
I'll try and bring everything forward to 1 o'clock. That would make perfect sense.
Super. I'm very grateful. Thank you very much indeed, everybody.